Assalamu alaikum and good morning. This is Pakistan Oculoplastic Association Symposium 5, which is about the eyelid. And I am here, Dr. Sadia Imtiaz, who will be the moderating this session, along with Chairperson Professor Amir Yaqub. Our first presentation is by Professor Zahid Kamal Siddiqui, which is about dermolipoma.
A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. I will start with recitation from Holy Quran. Afala yanzuruna ilal ibili kayfa khuliqat wa ila samai kayfa rufi'at wa ilal jibali kayfa nusibat. Sadaqallahul azim. Allah Almighty says, why don't you look at the camel, how it was created? So different parts of science God asked to look at. Right. This presentation we jointly prepared, Dr. Sadia and myself, and this is the place where I work, and this is my alma mater, King Edward Medical University. That is, Richard, one of the spot to, which is very historical, 150 years old building. So these are basically choristromas, and it consists of adipose tissue, collagenous skin adnexa, and it is covered by epithelium. And the epithelium is contiguous with conjunctiva, and sometimes it is adherent to lacrimal gland and an underlying osteoma. Well, I have never come across an osteoma, but it's written in the book. So, and there are certain associations of syndromes. Treacher's-Collins syndrome is quite visible in the roads at Lahore. If you see, they've got the lateral canthus slanting down, and sometimes there are other congenital abnormalities. Median age of presentation is 16 years, usually asymptomatic, more common in females, and they present with irritation in the eye or and defective vision and amblyopia are the associated features. The color is yellowish white, and they have fine cilia sometimes, especially in the examination. When we show you the cases for assessment purpose, it would be very diagnostic if you examine on the slit lamp. It should be differentiated from lacrimal gland, and especially the herniated orbital fat. Richard showed beautifully on the other day, and certain tumors. The management includes lubrication, refractive correction, amblyopia therapy. The indication of surgery are when it is visible in the visual axis and it is causing astigmatism and constant irritation. It is in the visual axis, it gives a bit of cosmetic abnormality, and in Pakistan mostly especially the female, they present before the age of marriage and they want to have it removed. Interestingly, in primary position sometimes it's not visible at all, so you need to ask the child or the patient to look down and away. So this child is looking to the left and down, and you can see the cilia. Goal of the surgery is to remove the visible part of dermolipoma. Do not go to remove the whole lesion, it may have problems. So we give incision medial to the lesion and then dissect deeply. We try to save as much conjunctiva as possible and also make sure that the lateral rectus is not damaged. But still the complications may arise, maybe strabismus for a short while, or it may persist. There may be symblepharon or dry eye, ptosis or persistence of lesion. This is a perhaps aborted type of lipodermoid, and you can see the fine difference is the lacrimal gland palpebral lobe, and the difference is quite visible. It's pale yellow and it is pinkish. So while removing, if it is a large one removing, there is risk of damage to the ducts. So you should avoid that. And Richard, that's the view you want to capture from Lahore. That's the old mosque, 200 years old mosque, and that's the monument of Pakistan that was built in 1960s. Thank you very much.
Thank you so much for this nice talk. Our next presenter is Dr. Farah Huma. Is she here? Okay, so Dr. Amara Ashraf, your talk is about how to avoid e-visitation in painful blind eye.
Assalamu alaikum and good morning. Today I am going to share how to avoid e-visitation in painful blind eye, especially in cases of panophthalmitis. I'm Dr. Amara Ashraf, doing a fellowship in orbit and oculoplastic at Armed Forces Institute of Ophthalmology. I have no financial disclosure and consent was taken to use patients' images. When a patient of panophthalmitis who has been treated in every possible way now referred to you for e-visitation, how do you manage such painful blind eye? For pain, we usually give topical, oral, or even IV analgesia until we go for evisceration. But losing an eye is not just a physical experience, it carries deep emotional and psychological repercussions. An ongoing study published in 2024 shows that the patient who had undergone an eye amputation had an early reduction in their health-related quality of life. In another study, participants stated that preoperative pain was a major reason to go for evisceration. In our study, the objective was to make patient pain-free and to avoid surgical and psychological trauma. We used Wong-Baker pain scale to assess the intensity of pain, and all our patients were rated 10. Some of the patients even reported that they could not sleep at night due to pain. The patient presented to us in this condition, either with extensive exudation or with significant corneal melting. At this stage of disease, we avoid evisceration and make patient pain-free with periocular antibiotics. We use injection vancomycin and injection ceftazidime in a dose of 50 mg in 0.5 ml. In cases of corneal melting, we combine this treatment with tarsorrhaphy. First of all, after disinfecting the periocular area, the site of injection is palpated and globe is pushed upward with finger. 23 gauge needle is used. First drug is injected in posteromedial direction. Syringe is detached and second syringe is attached. Now the needle is slightly retracted and directed posterolaterally to avoid precipitation. Usually our patients become pain-free after third dose of periocular antibiotic, but still if there is a complaint, we go for up to 5 on alternate days. Now I'm going to show a case. A 67-year-old male, known diabetic, which was uncontrolled, presented with painful blind eye for last 1 month. He underwent extra cataract extraction and developed endophthalmitis. 5 intravitreal injections were given elsewhere, but no significant improvement was seen. And patient vision has now become no perception of light. Condition of eye at presentation, there was organized exudation in anterior segment with irregular depth. Severe conjunctival congestion is also present. After first dose of antibiotic, to our surprise, his exudation was reduced along with pain. This is after second dose of antibiotic. There was further decrease in exudation and pain. Though there was no significant improvement in his vision, yet his exudation was reduced and pain was completely gone. However, this patient is still under treatment for exudation. Total 14 cases of painful blind eye due to panophthalmitis was referred to us at AFIO for evisceration. Only 1 underwent evisceration. Even this one case was doing fine and he was using artificial eye, but after 6 months, his IOL extruded through the cornea, so we went for evisceration. I thank you all.
Any questions for Dr. Amala?
Next speaker.
Ocular pressure where there is no perforation.
Sir, even with patient, there were some patient had corneal melting and the eye was soft, but even the pain was severe in those cases too. So that was very unlikely that it was due to high IOP.
Yeah, your next talk is
It's
about.
sorry, just a comment. I think it's a good idea in these patients to give them systemic steroids as well, because they tend to reduce the inflammation and pain as well.
Sir.
So, next talk is no xanthelasma is xanthelasma until biopsied.
Today I'm going to share a case which remained misdiagnosed for 8 years. My patient, 60-year-old female, weighing 76 kg, resident of Ahmedabad, presented with complaint of bilateral periocular plaques for last 8 years. My patient was in usual state of health 8 years back when she noticed multiple yellowish plaques over upper lids on both sides. Initially, these lesions were small, well-defined, and painless with flat surface. Gradually, over the year, there was increase in size and number of the lesion, which now involve whole of the periocular area. Her past history revealed that her lesions were considered xanthelasma, so she was once treated with cryotherapy, along with statins. Rest of the past history was insignificant. General physical examination revealed a well-oriented middle-aged woman of average built-in height with stable vital signs. Systemic examination was also non-contributory. Ophthalmic examination revealed best corrected visual acuity of 6/6. Anterior segment examination showed multiple large yellowish plaques 360-degree around both eyes. Temporal and nasal lesions were more enlarged and raised, and on palpation these lesions were non-tender, firm, mobile, and not adherent to overlying or underlying structure. Rest of the ophthalmic examination was unremarkable. Case summary. A 55-year-old female with multiple yellowish plaques around both eyes for last 8 years. She was misdiagnosed and treated with cryotherapy. Initially small and well-defined lesions has now progressed to large raised nodule with loss of regular margins. Provisional diagnosis of bilateral periocular xanthelasma was made, but to confirm the diagnosis, biopsy of the lesion was carried out. Biopsy report shows presence of foamy histiocytes and Teuton type giant cells. No degeneration of collagen was seen. These findings were suggestive of xanthogranuloma without necrobiosis. So a final diagnosis of bilateral periocular xanthogranuloma was made. To find out what type of adult xanthogranuloma she has, we carried out her systemic workup. Her treatment plan was devised for ocular lesions. Intralesional and course of oral steroid was advised along with excision of large nodules. And for systemic evaluation, we referred the patient to medical specialist to rule out other xanthogranulomatous lesions in the body. This is a post-recovery picture. This is just for comparison. Upon our referral to medical specialist, patient was found to have xanthogranuloma in the sellar region, which was causing diabetes insipidus. Her labs showed increased plasma osmolality, decreased urine osmolality, so her desmopressin was prescribed to her. I will conclude by saying always go for biopsy in atypical lesions. Thank you.
I think it's a great case, and I think it's very instructional in the sense that, if you see these atypical lesions, xanthelasma are so common that it's very easy to just say, oh, it's just xanthelasma. Another lesion that can mimic it is also amyloidosis, and so I've seen a few amyloid lesions. Those patients usually end up having multiple myeloma. So you end up, it's very serious when you look at these patients. So
Sir.
yeah, very nice case.
Thank you. Thank you, Dr. Maya, for your out of the box talk. Our next presenter is Dr. Sumaya Ali Khan. She will talk about outcomes of Fox procedure for congenital ptosis using silicone tube.
I'm Dr. Sumaya Khan, and I shall be talking about the closed method, Fox method of frontalis sling using silicone rod in our experience. Now, starting with, no, facial lata had been used as a suspensory material since the end of the 19th century, but in 1909 it was Pear who formalized it more, and Wright improved upon the technique in 1922, also devised the famous Tosa's needle. But in 1956, it was Mr. Crawford who declared it as the gold standard of treatment of congenital ptosis. And he started using facial lata for anybody above 3 years of age. But since that time, 70 years down now, we have a lot of other materials available as well. We have the silicone rod, Proline, Supramed, a few meshes like the Merceline and the Vital Mesh, and Gore-Tex as well. So my question to the House is from facial lata and the silicone rod, are they close competitors now? So the advantages of the silicone rod are that it's inert, it's adjustable, it's economical in terms of the surgical time. Also the cost is cheaper now because of more manufacturing available. The problem with the facial lata is, of course, the patient gets an additional scar. It has a learning curve for the surgeons involved. And of course, even if you use the banked facial lata, we need a proper cold chain and a proper system to bank it. So I did a bit of a literature research and found that a lot of people have found that facial lata and silicone rod are comparable. And in one of the studies by Mr. Lee Min Jong on the right-hand side, it actually proved that in their practice, silicone rod was much better in terms of cosmesis and the longevity of the outcomes. So at Al Shifa, Rawalpindi, where I work, we use the silicone rod fairly commonly for pediatric cases, especially the ones at risk of amblyopia. Majority of our patients are not willing for facial lata, not even for the banked one. And in unilateral cases and adults with CPEO and cutis laxa patients. So the method used is, we are all aware of this pentagon or the trapezoid method of frontalis sling. In our practice, we also found that it's not always, the closed method works as good as the open method. So instead of attaching the rod to the tarsal plate, sometimes threading it through and bringing it out above the brow incision does the trick. So I hope the picture is clear. This is of a lady who has histologically proven cutis laxa, the elastin fibers of her periocular area. We took a skin biopsy as well, and it's complete degeneration. So we've done multiple times frontalis sling for her. Her eyes completely closed otherwise. Here's another gentleman who was absolutely not willing for facial lata. He had congenital ptosis, never been treated before. The pre-op picture shows that he had a lot of frontalis overaction. The picture on the right is of the first post-op day. Another lady, not willing for facial lata, not even the banked one. We used the silicone rod and she's faring quite well. The picture on the right is of her first post-op day. She's still in follow-up 1 year down the line. She's quite happy. Whenever we take a history and we even try to in order to keep ourselves in practice for facial lata, our patients are not willing. And the balance always tips in favor of the silicone rod. Obviously, the long-term follow-up remains to be seen, and there is a small risk of foreign body reaction to the sleeve used, but we don't see it that commonly. So I would just like to put a question across to the House, whether this is the same observation in their practice as well. And I would like to conclude by saying that don't practice until you get it right. Practice until you can't get it wrong. Thank you all for your patient listening.
Any questions?
I still use silicone in adults. In kids, I actually now do a frontalis flap. And I think that that's something, frontalis muscle flap is something that I changed to about 7 years ago. I used to do a lot of silicone in children, and I moved to frontalis flap just because of the fact that I only make a lid crease incision. and I also don't have the foreign body concerns, and I think it's longer lasting than silicone. So I really encourage you all to look into doing to switching over to frontalis flap. I was sort of forced to do it in the sense that I used to see my patients in Houston. They would come and ask me if I did a frontalis flap, and when I said that I didn't, they'd say, "Thank you, we're going to go to Spain to have it done." And so after that happened to me about 10 times, I said, I need to learn this procedure. And I have, and I've been very, very happy with it. And that way you don't have to worry about getting an implant. There's no cost to it. It's just one incision. And I think it's probably longer lasting. So I'm a big believer in it now. I wasn't 7 or 8 years ago. I was not a believer in it, but now I am.
Islam is an advocate of that. You are also.
Yeah, I'm also doing it occasionally, but I've grown fonder of using the silicone over the past few years, and I'd like to fixate it with the tarsal plate because silicone has a elasticity, and if you don't fixate it with the tarsal plate, it tends to cut through the tissue cheese wires from the and move up, so you lose the effect of the silicone after some time.
So we had probably because of the bias was because we used it more in children. We noticed that when children, when they cry, they squeeze the orbicularis more, and it sort of slipped from the top position, and when it was attached to the tarsal plate. So the squeezing, but when we don't attach it to the tarsal plate and it's threaded through, it lasted longer. So a lot of us probably do it with
For
the
the
closed method now.
for the upper, I think fixation, you need to use a non-absorbable stitch and stitch it with the frontalis muscle.
We
So
Probably our
then it
technique
doesn't
was-
generally then it doesn't slip from there.
Right, regarding the when you are selling sort of a procedure to the patient, so it's a lot of bias from the surgeon side. If you are a fan of silicone, you will put it in a way that is okay, I'll go for it. So most of the time, when I present different options, so they're convinced for fascia lata. Now we are going to publish a series of allogenic fascia lata, Sadiami and Farahuma. I think 25 cases. So we use fresh, obviously, after viral screening. So we take from a bigger patient and then multiple use.
Yeah, I think this is a very interesting debate because it's something that a lot of people disagree on. There's no right or wrong answer. I think everybody has their preference, and a lot of it is what works best for you. So like in the U.S., a lot of people don't do frontalis flap. I'm one of the few that does, and it's just very interesting because it's a lot of people have very strong opinions with regards to what is the best thing to do for these patients. It's interesting.
So Zahid, how do you store it, sir? The fascia lata once you take it
Don't
from a
need
bigger.
to store it. We have patients side
Just-
by side.
Okay. Thank you.
Thank you, Dr. Sneha. Your talk actually created a very productive discussion. Moving next to the towards ptosis management, I would like to invite Professor Amir Yaqub, who will discuss about the levator resection. से मैं remove करा देती हूँ.
Right. So what I've done is that I've made a video. Won't show any go into very details and of anatomy and stuff, but just go through the important preoperative examination, what you need to do, and go through the steps of the surgery. Right. So you do some important measurements. One is the MRD to find out what the levator amount of ptosis. Then you do see the pretarsal show, which obviously is more on the ptosis side. Levator function is obviously very important. It's about 9 millimeters on the ptotic side, and you need to measure the upper lid crease. So once you've done that, you need to know the Bell's phenomenon as well. You start with putting some local anesthetic drops and defat the skin so that your mark doesn't disappear when it is cleaned by iodine. You mark the lid crease and then inject the local anesthetic just underneath the skin. You don't need to go too deep, because if you go too deep, you're likely to end up with a hematoma. So you inject about 1 to 1.5 ml of adrenaline with lignocaine with adrenaline. So you put in a traction suture slightly medial to the center. Uh, that is the highest point of the lid, and you go through the skin and the orbicularis oculi. Uh, Once you go through the orbicularis oculi, you come to a white plane underneath the orbicularis. Once you're there, you then ask the assistant to put traction on the lower part and go between the orbicularis and the tarsal plate to expose the interior surface of the tarsal plate. Once you've done that, then you dissect superiorly between the orbital septum and the orbicularis and expose the orbital septum. So here you can see the orbital septum. You put in a Jaffe retractor and you see the orbital septum. You can push on the lower lid to see the fat prolapsing. Once you open the orbital septum, it's the levator is the tissue that is lying underneath it, the preaponeuritic fat. You can see the Whitnall's ligament here. So once you open the septum, you retract the preaponeuritic pad of fat, and then you dissect the aponeurosis from the tarsal plate, which is inserted on the interior surface of the tarsal plate, just about a millimeter or two below the upper border. So you dissect between the aponeurosis and the Mueller's. You can see the Mueller's, which is quite vascular. And once you go above the Mueller, it's the fat comes in, so you stop dissecting there. So you can see the fat above the Mueller's muscle. So once you've got the aponeurosis, then you pass a double-armed 5-0 vicryl through the tarsal plate. Make sure that the stitch is not through and through, because otherwise it's going to irritate the cornea. And then pass it through the aponeurosis. Ask the assistant to pull the aponeurosis down and tie it temporarily to see the lid level and compare it with the two. You need to overcorrect it a little bit because the orbicularis here is paralyzed because of the local anesthetic. So once that recovers, the lid is going to go down a little. So once you are happy with the lid level, then you tie it permanently. And just to avoid the lateral droop, you need to put in a lateral stitch as well. Again, making sure that it doesn't go through and through the tarsal plate. And you pass it through the aponeurosis again. Tie it temporarily first to make sure that the contour is okay. You check the contour again. If you're happy with the contour, then you tie it permanently. So once you've done that, you excise the excess aponeurosis on both sides and then cauterize the edge, because sometimes it bleeds a little. Once you've done that, I remove a strip of orbicularis from the lower part of the incision. You ask the assistant to retract the skin and remove it. This reduces the amount of postoperative swelling and improves the recovery a little bit. If then you can also do a little bit of upper lid blepharoplasty if you feel that the skin is excessive. Generally, you need to do it in more older individuals. For children, I tend to avoid that. So once you've done that, then you close the incision by taking a bite of the levator, skin, levator, and skin. So you pass about 2 or 3 sutures like that of 7 Vicryl. I use absorbable sutures in my surgery so that the patient doesn't have to come back for suture removal or anything. So the rest of the skin is closed, just skin to skin, and you patch it for about an hour or so that if there's any ooze or anything, then you can check it after an hour and then let the patient go home. So thank you very much. That's how I do it.
Any questions or comment from Professor Amir?
I've never cut the horns, not ever in my life. And I think I feel that if you cut the horns, you lose the 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 pulley function of the epineurossus, because the horns, they are suspending from with the Whitnall's ligament with the roof of the orbit, and that gives the elevator a sort of 90-degree bend when it's coming from uh, posteriorly from the orbit and then turns down into the eyelid. And if you cut the horns, that physical support goes, and it loses its I think advantage, the pulley advantage. Thank you. You can vary that depending on what the amount of ptosis is. In congenital ptosis, if you can go down on the tarsic plate as well, or if you are repairing just the epineurossus, in involutional ptosis, you can just suture it with the upper border of the tarsic plate. It depends on the levator function, basically, how far you want to go down.
Thank you so much, sir, for actually showing your beautiful fine work. Now, I would like to invite our guest speaker, Dr. Richard Allen, who has actually traveled all the way to Pakistan to teach us and to show his expertise to us. Kindly, sir, join the podium and let us know about minimally invasive brow elevation.
All right, thank you so much. It's interesting to watch your surgeries because there are little things that you do that is very similar to what I do, and it's due to the fact that he and I are sort of trained under the same lineage. His mentor, Brian Leatherborough, was trained under my mentor, and so it's interesting to watch because there's these little things that you do that I was like, oh, that's very, it really is, and you'll notice that in people that have trained under the same people. Anyway, what I'm going to talk about first is about minimally invasive brow elevation. This is a relatively long talk, so please stop me if I'm going too long, okay? But truly, don't hesitate to stop me if I'm going too long. Again, I have no financial disclosures. I think, first and foremost, we always have to tailor our brow technique to the patient, and this really depends upon the degree of the brow ptosis, the contour of the brow ptosis, the gender of the patient, the goals of the patient, whether the patient has any good wrinkles, the height of the forehead or the hairline, and then also the hairstyle. I think it's always good to remember that, women and men have different brow shapes, and so you don't want to feminize the male's brow, you don't want to masculinize the female's brow. And also, every patient has different goals in the sense that some patients don't want to go through too much, some patients are willing to go through more. Males can be difficult, because their contour is flat. It can sometimes be difficult to lift their brow, especially medially, with some of the techniques that are available and easy to do. They often have a high hairline or no hairline due to the fact that they have alopecia. The weight of the brow is also heavier than in women, and they often have very thick skin. So, this is something to keep in mind when you're choosing your techniques between males and females. What I'd like to talk about, though, is some of the less invasive procedures for brow ptosis. We have direct browplasties, we have mid-forehead browplasties, we have retracheal browplasties, and these are relatively pretty invasive and leave visible scars. And so what I'd like to talk to you about today is what I do for a lot of my patients who just need either brow stabilization or 3 to 5 millimeters of brow elevation with their blepharoplasty. Almost every patient that I see that is going to get a blepharoplasty, I almost always consider doing something for their brow, because I think there's always a little component of brow ptosis in every patient that you look at for a blepharoplasty. And you know, when I used to do these patients, I used to do a lot of endoscopic brow lifts, but now I've sort of moved over to a brow pexy, which I really like because it provides stabilization, and it can give me a little bit of elevation, but always respect the fact that a brow pexy is a relatively weak procedure. And you know, what we're doing with the trans blepharoplasty brow pexy is that we're using the blepharoplasty incision to push the brow up, and then usually we're fixating that to the underlying periosteum. But like I said, excuse me, the disadvantage is that this is a weak procedure, and it's really a stabilizer. So if I really need elevation, I'm going to do something else for these patients. But the nice thing about this procedure is that it doesn't use an additional incision. And so, you know, when we do this technique, we're just doing a blepharoplasty incision. We're dissecting between the orbicularis muscle and the orbital septum up to the superior orbital rim. And then we're doing a pre-periosteal dissection. We're fixating this, and then we're closing the blepharoplasty. I think that when I first was thinking about doing brow pexies, I had a lot of problems because I just didn't know where to place the suture. I was always like, okay, where am I supposed to place the suture with regards to the periosteum and then also the soft tissue above it. So now I quantitate this procedure, and I think the nice thing about quantitating this procedure is that it does the same thing to both sides. It keeps symmetry, and it sort of makes sense to what I'm doing. So, you know, basically I'm just making an incision just along the surface of the orbital septum to the superior orbital rim. And so I'm just going to follow the anterior surface of the orbital septum to the superior orbital rim, and then once I identify the superior orbital rim, I'm going to dissect in a pre-periosteal fashion. So I'm just using a periosteal elevator to do a pre-periosteal dissection in this area above the superior orbital rim. And I'll usually extend this dissection about 2 centimeters, and then I'm going to measure from the superior orbital rim, and this is usually about 12 millimeters or so, and I'm going to place this suture, which in this case is a 4-0 vicryl suture. I place either vicryl or a monocryl suture, so an absorbable suture. I'm then going to make the same measurement from the edge of the skin to the soft tissue here, and I'm going to place the suture there. So basically this quantitates my brow pexy. This is engaging the soft tissue or the brow fat. And essentially what this is doing is this is placing the incision at the superior orbital rim. So this is similar to what people would call a brassiere suture, except with the brassiere suture, you're making the fixation much closer to the skin margin. And so this places my brow in a position that, you know, is essentially putting the incision at the superior orbital rim, which is very loose. I mean, it's not a tight adherence. I mean, so I you know, sometimes you get a little lag ophthalmos after this at the end of the surgery, but not too much. And so these are just a few patients before and after. So, you know, the big thing to always remind yourself is that by definition, if we do a blepharoplasty on a patient, we're going to draw their brow down. Study after study has shown that, you know, you get a descent of the brow at least 1 millimeter in patients after you do a blepharoplasty. And, you know, this keeps the brow pexy just keeps the brow in position. Same thing here. If I take off extra skin here, I'm going to draw this brow down. This sort of keeps that brow in position. Same thing here. And I've altered this technique a little bit now in the sense that now I do what is called an extended quantitated brow pexy. And again, I'm doing the same dissection that I did before. I'm doing my blepharoplasty, then I'm going to dissect along the surface of the orbital septum to the superior orbital rim. So you're dissecting between orbital septum and the orbicularis muscle, then you're dissecting between orbital septum and the brow fat. So I'm trying to keep brow fat up. I'm just trying to dissect along the orbital septum, identify the superior orbital rim, and just like before, I'm going to dissect above the superior orbital rim in a pre-periosteal plane. Okay, and this is with the freer periosteal elevator. I do this for about, just like before, 2 centimeters. But rather than place my suture now, what I'm going to also do is extend a subperiosteal dissection above this periosteum. So I'm leaving a cuff of periosteum at the superior orbital rim. I'm just using the monopolar cautery to make an incision through the periosteum above the superior orbital rim. And then I'm going to do a subperiosteal dissection superiorly. So this just gives me extra elevation of the brow. And often I'll identify the supraorbital neurovascular bundle over here. And what this allows me to do is just push that brow up even more, okay? And this dissection is subperiosteal. I can go pretty high with this. There's nothing up there that I'm going to hurt. Laterally, I need to be careful of the conjoint tendon or the temporal fusion line. I'm not going to go too far laterally. I can try to expose the supraorbital neurovascular bundle up here, but this just allows further mobilization of that brow so that when I push it up, it will stay in that position a little bit better. So when I look at this, I'm getting probably about 2 to 3 millimeters of elevation of the brow, whereas before with the brow pexy, I was only getting about 1 millimeter of elevation. And so I'm just doing my quantitated brow pexy just like I did before, placing a suture through the periosteum, and then again measuring from the edge of the skin, placing that suture there, and that's it. Okay, so getting a little more elevation with this, and I sort of like this. So I consider this, I do this a lot for patients that are undergoing blepharoplasty as well. So very, very common. Now, the good news for males though is that usually they don't want very high brows, and much of what we're doing is just to enhance the blepharoplasty. But this is a patient where I didn't do anything, but I only did a blepharoplasty. He didn't want me to do anything to his brow. And you can see that I have drawn his brow down. So I think it's important to consider a brow pexy in these patients. And I mean, this is my go-to procedure at this point for these patients is to do a brow pexy with blepharoplasty, but extend it by doing the subperiosteal dissection superiorly. Again, more of an aesthetic procedure for patients, but I think rather than doing a direct brow lift or doing something more extensive, this is something that's pretty easy to do. Only will take you maybe 15 minutes to do total in your surgery to add to your blepharoplasty, and gives patients a pretty good result. But anyway, thank you very much, and I'll be back to talk about facial nerve palsy.
Now I would like to invite Professor Imran Akram Sahab, whose talk is about keep your chin up.
Assalamu alaikum. We have been talking about different ways of correcting ptosis, especially the sling procedure. But we have not been talking about the results, because the sling procedure, it has got certain problems. The purpose of the ptosis surgery is basically to have equal lid apertures in both eyes, and also in all positions of gaze, especially looking right, left, or up and down. The purpose of frontalis sling is just to connect frontalis with the lid margin. Normally this connection is loose when the frontalis is working, it's not picking up the lid properly. So we make a rigid connection so that the contraction of frontalis is fully transmitted to the lid margin. So just discuss that. So number one, once we have done this procedure, frontalis is not basically ready for this procedure, it's not strong enough, and amplitude of contraction may not be sufficient.
And what we do is, to compensate for that, we further tighten the sling, and that increases the exposure. And then the other problem is frontal is not synchronized with the levator of the other eye. So how you can get the same aperture? Again, it is difficult. So for these purpose, we suggest to the patient to have exercise in front of the mirror, forcibly closing and opening. That creates a better amplitude, gives elasticity to the movement. It also helps to achieve coordination between frontalis and the levator. Patient sits in front of the mirror and just practices. But this is a learned reflex. This is not present normally, so he has to create it by looking in the mirror. But the biggest problem, frontalis contracts only when consciously done. It's not contracting all the time. When you are doing something else, you are not conscious, you are not conscious of your eyes. The frontalis tends to stop working and has a lid droops. If you tell this child to open his eyes, he can open very well. But when he's looking like, especially when looking down, you can see the ptosis. And so when this child comes to us and he says, my eyes are not fully open, so I will tell him, I will revise it and make it more tight and this and that. So this is not the answer. We are correcting it anatomically, but not physiologically. Whatever material we use, the problem still remains. The other big problem is that when you change the position of the head, look, head down, up and up, the lid position changes. In all the positions, it's different in different positions. Now lid is more open than normal. There you can see this girl, you can see the changing position. All these pictures are without frontalis working. As she puts her chin up, stands to open. Here both eyes are equal. And again becomes a aperture becomes larger. So this is the problem. You all talk, ये कर दो, वो कर दो, वो लेकिन ये तो देखो उसके results क्या हैं. So we use this phenomena to our own advantage. We use this phenomena to our own advantage. How? As the patient raises the chin, the palpebral aperture progressively increases in size. So here you can see no frontalis working. Apparently both eyes are equal. Both eyes are equal. So what we do, what I do is, we make use of this property. So the aim of sling surgery is the aim of my sling surgery would be to tighten the sling to the degree where the chin elevation to a socially normal position. We don't want the patient to excessively raise the chin or keep the chin down, but so as to achieve a cosmetically equal lid apertures. Okay. Normally, how would you like a person to have a head posture? Upright, straight looking, more socially acceptable, not head down or not head up. So we tighten it to this position, and then we train the patient in front of the mirror. He tends to adopt a posture which is required to keep the eyes equal, even when looking to the right and left. And also while looking down or up. So when he's looking up, he raises his chin. And looking down, he drops his chin, bows his head. And in all positions, both eyes keep looking the same. But patient has to train for it. And it's amazing how the patients, they learn how to do it. They just keep their head posture correct. Asymmetry has always been a problem for this operation. And it's unsatisfied patients, and we just are tightening the sling as much as possible and increasing the chance of exposure, especially during night. So posture correction with chin position, extremely easy way to achieve symmetry. And the patient learns it very quickly and adapts to it. And it boosts the confidence of the patient. Otherwise, यही पेशेंट जो होते हैं, they keep their head down because of the asymmetry. We tell them to keep their head up, keep their chin raised, rather than just trying to hide their deformity. Thank you, sir.
Any questions or comments? Thank you so much, sir. You always come up with some innovative ideas, and you are a blessing for all of us. Next, moving forward to our next talk, which is about treatment of the ptosis surgery-related complications by Professor Khaja Khalishwar.
Thank you very much. Ptosis surgery is very rewarding. You get beautiful results. But sometimes problems do occur, complications of ptosis surgery. So a surgeon should be aware of those complications and should be ready to address all those complications. So uh, the most frequent complications are undercorrection, overcorrection, lag of thalamus, and crease asymmetry. I have done about 270 cases of levator resection, and in 5 cases I encountered overcorrection. Now, in most of the cases, these were the cases that were done under general anesthesia and the levator function was good. So that resulted in overcorrection. So whenever the levator function is good, try to minimize the levator resection. This is my conclusion. So in one case, the overcorrection was moderate, and by pulling the lid down in 4 weeks, the condition improved. However, in 4 cases, the overcorrection was severe, and two required one operation and two required two operations. Those who required one operation in one hand bag technique with 5-0 ethibond was sufficient, and in the second, the cutting the central half of the levator was successful. In those who required two operations, hand bag sutures with 6-0 vicryl was successful, and cutting the central half of the levator was gave the satisfactory condition. So this was the patient who was operated, and after the operation, the post-op picture was satisfactory, but after 2 weeks, the patient developed overcorrection. Now I applied a suture and stitched, sort of taped it down, and asked the patient to pull the suture so that the lid remains under correction, and after about 3 weeks, the condition improved. So this was another technique which I used. By averting the lid just above the tarsal plate, you make small cuts in the conjunctiva and in the levator. This is for mild overcorrection. So uh, this I found useful for only mild overcorrection. So cutting the levator gave a little bit of relief. See, when a patient comes with overcorrection, we have to lift the contralateral lid to see what is the true extent of the overcorrection. You see, by lifting the contralateral lid, the operated lid has come down. So this is the true extent of the overcorrection. So this patient was also advised to pull the lower lid down, and in about 4 weeks, the condition improved. So in mild overcorrection, I would recommend only pulling the lid down. Now, this was another patient in which the overcorrection was severe, and I advised the patient to uh, pull the lid down, but it did not correct. So I had to do the surgery, and after surgery, the lid overcorrection was corrected. Now, for these cases, severe cases which did not respond to only pulling, I applied hang bag sutures. just like we do in the suture, in the squint surgery. This is the tarsal plate, and this is the tarsal plate, and this is the levator. So these are the hang back sutures. 50 ethibond in one case, and this is 50 ethibond, and 60 vicryl in one case. So scleral patches of preserved sclera and fascia lata have been described in the literature as spacers, but I did not find those, so I could not use those. So this is another case in which
So this is a case of slight overcorrection in the left eye after ptosis surgery. Also, we will.
this is slight overcorrection, and I will. I just made nicks in the levator muscle, only cuts in the levator, central part of the levator, so that the levator was, half of the levator was cut, and this gave rise to correction of the overcorrection. So this is the patient before the operation pre-op, and this was overcorrection, and this was corrected by making cuts in the levator. This patient was my one of the earliest operations, and this was the pre-op condition. Once I operated, she developed exposure keratopathy. In this age, some of the eyes are dry, and you have to keep in mind that the tears may be less. So I had to redo and overcorrection, and to address overcorrection, I did a little bit of undercorrection. So the patient was not happy. Patient said the first appearance of full correction is good. So I have noticed that cosmesis is important even at this stage also. So we cannot underestimate the importance of cosmesis at 90 or 80 or 90 years of age. So coming to the proline frontalis sling, I have done fascia lata, but I have done more of frontalis sling with the 20 proline suture with a long needle. And I have done about 300 cases, and I found complication in 3 of the cases. In one of the cases, the knot was a little bulky, and it cut through cheese white through the skin and appeared. So pushing it back and applying a suture was sufficient. In other case, the patient came back with cellulitis, and this was the case in which there was severe this patient had poor Bell's phenomena and developed exposure keratopathy. So in such cases, one should have slight undercorrection. And so this was the exposure keratopathy, which improved in 4 weeks with artificial tears. Thank you very much for a patient listening.
Thank you so much. Knowing the management of complication is as important as knowing the procedure, of course. Thank you so much, sir, for sharing your experience. Moving forward, I would like to invite Dr. Ubaidullah Yassin, whose topic is about the minitosis.
Bismillahirrahmanirrahim. Assalamu alaikum and very good morning. The complete topic is minitosis surgery. That is basically Mueller levator plication. Ptosis is a prevalent condition, and lot of methods are being practiced to correct it. And here is a sequence of my presentation. Basically, I have done a transconjunctival threading to get tucking of Mueller and levator aponeurosis with tarsus. This method is minimally invasive. Hardly it took 5 minutes, bloodless, lesser operative time, and especially useful on elderly and especially on anticoagulants. The most important prerequisite is good levator function. If good levator function is poor or there is neurological ptosis, then it is contraindicated. and it is also contraindicated in congenital ptosis. A double-armed non-absorbable suture is used to ligate the Mueller levator and tarsus complex. And here is the final state after ligation. First of all, we have to give anesthesia without sympathomimetics. In just like while giving the technique we use while giving supratarsal canacard. A fixation forceps that is self-locking is used to hold the upper border of tarsus, and it is from 5 millimeter from the lid margin. Then lid is everted, and on fornix side a marking is done 5 millimeter away from the tip of fixation forceps. A 5 millimeter wide incision is marked, and incision is created with monopolar cautery or high frequency cautery, but taking care not to damage the Mueller, underlying Mueller. Then coming back, a 5 millimeter wide mark is marked at tarsal plate from 3 millimeter of the lid margin. Now take a 7-0 double armed Prolene suture, pass a needle through the fornix incision, pass through the Mueller, and come on tarsal plate side, and then reinsert and thread the needle through the tarsal plate. Almost this bite is 5 millimeter wide. Then reinsert this needle through exit point backward and come on the other side of the conjunctival incision. Now hold the central section of Mueller muscle using St. Martin forceps, almost 5 millimeter wide bite. Insert the needle until it has reached the Mueller muscle and the posterior levator of posterior layer of the levator. The same threading is done from the other side, and ligate this suture, tie it. This is a short video, first of marking the highest point. Lid is everted, 27 gauge needle is used, and 0.5 cc lignocaine without adrenaline is given. To protect the cornea, cornea shield is placed. This is self-locking fixation forceps. Hold the upper part of tarsal plate. Double version done. Marking done on fornix side. Needle of 7-0 Prolene is passed as described earlier. It is retrieved on tarsal plate side. Rethreaded and retrieved again on fornix side. Mueller and levator holded, and this Prolene needle is passed through both structures. At the end, both lips of the conjunctival wound they are raised and sealed with bipolar cautery so that underlying Porolene suture should not be damaged. This is the pre-op picture of the lady, and this is just post-op. This procedure has fewer complications, slight under-eye overcorrection, eyelid swelling, and subcutaneous eyelid bleeding. Over last 1 year, we have done almost 100 cases, and 4 cases with under-eye overcorrections reported. I conclude by saying that minimally invasive torso surgery has minimal impact on shape of the eyelid, and moreover this procedure is reversible, redoable, and it is much helpful in elderly patient with involutional torsos and on anticoagulants. Thank you.
Thank you so much, sir. This was really a very good presentation. Any question or comment to make from the audience or from the... So I have a question. You have used non-absorbable suture. Any DCL was placed afterwards, or the patients were complaining?
This goes backward into fornix,
But
and it is buried, deep buried.
you say one was placed which was from the tarsal side. When one knot that goes from the tarsal side.
No,
it
no,
won't be causing
there is
any
no
injury?
knot on the tarsal side. When you retrieve the suture and the needle on tarsal side, then reinsert from the same side.
Yeah.
There
Okay,
is
from
no
the same
exposure
side.
of suture.
Okay.
डॉक्टर वैद ये काम कैसे करता है? How does this procedure work?
सर बच्चों में जैसे बचपन में शलवार पहनते थे ना, तो नड़ा वो जो इलास्टिक है ना बच्चे की वो ढीली हो जाती थी. बच्चा आता था जी कि अम्मा जी गिर रही है, तो माँ क्या करती थी कि वहाँ से थोड़ी सी इलास्टिक निकालती थी और उसको गिरा दे देती थी.
यहाँ तो इलास्टिक नहीं लगा हुआ पहले से. फोल्ड कहाँ पे आती है? फोल्ड कहाँ पे आती है?
सर फोल्ड ऑन एंटीरियर सरफेस ऑफ टार्सल प्लेट.
नहीं नहीं नहीं, आपने ऊपर से खींच के उसको टार्सल प्लेट से खींच दिया, ठीक है, अंदर ही अंदर से. तो आपने उसके ओरिजिनल इंसर्शन को टाइट करके क्रीप कर दी, तो उसमें फिर फोल्ड आ गई ना कॉन्जुमेटी और उसमें भी. नहीं नहीं नहीं, फाइन फाइन, शुक्रिया.
Now I would like to invite Dr. Richard Allen again onto the podium to talk about periocular treatment of facial nerve palsy.
Okay, again, I may go a little long on this. I can talk about facial nerve forever. I love taking care of my facial nerve palsy patients. And so again, just stop me if I'm going too long. Again, no financial disclosures. I think one of the most important things when you see a patient with a facial nerve palsy is make sure that you know the cause of it. I can't tell you how many times I've seen a patient that has been diagnosed with the Bell's palsy and then ends up having a tumor. Those two things present very differently. A Bell's palsy is pretty acute. It happens, the patient can tell you the day that it happens, whereas with a tumor, it comes on very, very slowly. And so, always listen to that history. It's also important to know, have an idea of whether you expect the facial nerve palsy to recover or not. With a Bell's palsy, it should recover. And then after some surgeries, talk to the surgeon. Sometimes they'll be able to tell you whether they expect recovery or not. Previous ocular history is always important to know because, if they have any glaucoma or macular degeneration or diabetes that is being treated, that may affect whether you can do a tarsorrhaphy or not. But most importantly, I think it's important to know whether the patient has feeling on that side, because the patients that get themselves into trouble with facial nerve palsies are patients that have also a neurotrophic cornea or neurotrophic keratopathy. And, if they can't feel that their eye is getting dry, then they get themselves into a lot of trouble. That's the first thing I ask the patient is I ask them, can you feel when the eye gets dry? And if they say no, then I'm worried. I also make sure that my technicians or nurses or residents don't give any anesthetic drops prior to my seeing them, because I will also check corneal sensation. Because if they have poor corneal sensation, I know these are patients that I'm going to have to watch closely, because if they have good corneal sensation, they're usually going to come back and tell you if they have a problem or not. When I think about treatment of these facial nerve palsies, I sort of separate them into an acute treatment and then also rehabilitation or chronic treatment. Acutely, it's very simple. We're just trying to protect the cornea, and this is done with lubrication, sometimes tarsorrhaphy, sometimes an early upper lid weight, and sometimes also a scleral lens. Lubrication 4 times a day with drops if they're not keeping it under control, increase that. I use preservative-free artificial tears if they're using it more than 6 times a day, and then ointment at night, sometimes ointment during the day. I don't think plugs really help, just because, the tears aren't getting out anyway, because usually they have a little bit of lower lid malposition, and then sometimes the patients will tape the eye at night. There is a component of meibomian gland dysfunction in patients with facial nerve palsy. We did a study a while back where we looked at meibomography in patients with a unilateral facial nerve palsy and found that they do have an issue with meibomian gland function. And this is due to the fact that when you close your eye, when you contract your orbicularis and the muscle of rheolin, this causes the glands of the meibomian glands to empty. And so if you don't have that contraction, the meibomian glands don't empty. And so, I think it's important to consider putting a component of meibomian gland hygiene into these patients. So warm compresses, I think, are important just to keep the meibomian glands running as well as possible, because we saw that with time, the meibomian glands drop out in these patients. For tarsorrhaphies, I don't do a lot of tarsorrhaphies for patients long term. I think it's a good threat, and what I mean by that is when a patient comes in and they're obviously not using their drops, and I tell them, I'm going to have to sew your eye shut if you don't use your drops. Miraculously, they start using their drops. And so I don't do a lot of tarsorrhaphies long term, just because I think we have better treatments otherwise. But, there are different types of tarsorrhaphies to consider. We have temporary tarsorrhaphies, we have permanent tarsorrhaphies. Temporary can be suture, bolster, glue, even botulinum toxin, whereas with permanents, we're looking at lateral, medial, and then a pillar tarsorrhaphy, which is one of my favorite things to do. So I do a lot of pillar tarsorrhaphies because, it allows easy examination of the eye, but also it's easily opened in clinic just with topical anesthetic. And you can open it up slowly, you can open up one of the pillars. But this is one of my favorite tarsorrhaphies to do for patients. You just put 4O silk suture through the upper lid margin, evert the lid margin, and then use an 11 or a 15 blade to make you're just making sort of small Hughes flaps that get reflected and connected to the lower eyelid. So we're just making incisions through the tarsus there, just about 2 millimeters inferior to the superior border of the tarsus. And then we're just going to develop this little flap of the tarsus with the conjunctiva. And then this just gets, basically just gets reflected down to the lower lid. I'm then going to just denude the lower lid margin a little bit and de-epithelialize it, and then I'm going to engage each of the flaps with a double-armed 5O or 6O vicryl suture, and then the flaps just get connected to the lower eyelid, and these sutures stay in for about a week. So pretty easy to do and really easy to open. And the nice part is that you can keep an eye on the eye. You can watch the eye as you go. So very easy to do. You just tie those, and that's basically it at the end of the procedure. You can see what we have. So one of those things that I like to do a lot. Sometimes I'll put an early upper lid weight, especially if the patient is going under surgery by a doctor who's going to transect the optic or the facial nerve. Usually I'm going to put a 1.2 gram weight in. Scleral lenses, I don't know how much access you have to these in Pakistan, but I love scleral lenses. They've really saved my life. Basically the way they work is that they rest on the sclera, and they have this reservoir of fluid under the lens. And these scleral lenses have really saved me in patients who, traditionally I would have done a tarsorrhaphy for them. With regards to long-term rehabilitation, really we're looking at the brow, the upper lid, the lower lid, and the mid-face. And again, I try not to do too many tarsorrhaphies. With regards to brow ptosis, a lot of different techniques. I don't do brow pexies in these patients because I think it's too weak. I love direct brow plasties in these patients. I think it's predictable, they last long, and they heal very well because you're making this incision in an area of paralysis. And so scars heal better when they're made in areas, when incisions are made in areas of paralysis. I think the disadvantage, though, is that it's sometimes hard to take this too far enough medially, and sometimes the medial brow will sort of be, will dive down, and so we need to bring up that medial brow, and the way in which I do that is with a little medial cutback. So this is a pretty generous direct browplasty for this patient. I just dissect, under the subcutaneous fat, and then I'm going to close this defect with deep interrupted 4-0 vicryl or monocryl sutures. So this is the cutback that I'll do for these patients to help bring up the medial brow. So I just do this in facial nerve palsy patients, and I take off this little Burroughs triangle and then close this spot, and that will bring up the medial brow. And then I just close this again with a deep 4-0 vicryl suture, and then through the skin I'm just going to put vertical mattress 5-0 proline sutures in the area of the cutback, and then I just run a 5-0 proline the rest of the way. And so we can see this patient here, you can see their brow, the brow scar here, how well it heals. It heals very well. And you can see that it just, it really heals well in these patients. Again, another patient, you can see the incision here heals very well. So sort of my favorite thing to do for brows. With regards to upper lid closure, we have static procedures. We have dynamic procedures such as springs. I believe a lot in weights. I think the questions with regards to putting weights in upper lids is whether you're going to place gold or platinum, or whether you're going to place it low versus high. I like platinum just because gold has a hypersensitivity of about 5%, and so if that happens, the weight needs to be removed. So I prefer platinum over gold. I place high weights now. I no longer place pre-tarsal weights, but I place them above the tarsus. The reason for that is that they're not as apparent. I have fewer exposure issues just because I have more tissue over the weight. It does not induce any astigmatism, whereas pre-tarsal weights can. And I also can correct a little bit of the levator contraction. But this is the problem with long-term pre-tarsal weights, is that you eventually see these weights. So the way in which I place a high weight is that I just place a lid crease incision, dissect through the orbicularis muscle to the underlying orbital septum. Then we're going to open the orbital septum. I'm going to identify the pre-aponeurotic fat, dissect the pre-aponeurotic fat from the underlying levator aponeurosis. I'm then going to disinsert the levator aponeurosis from the underlying tarsus, and I'm going to dissect between the levator aponeurosis and the underlying Mueller's muscle. And then this weight is going to be placed above the superior tarsus between the levator and the Mueller's. So it's high. And this is going to be a platinum weight because I like platinum. I almost always place 1.2 gram weights. And this is just going to be sutured to the lower holes with 6-0 proline suture. And then the levator is going to be be placed over the weight. And now this is not, the levator is not being reconnected to the tarsus, but it's actually being connected to the pre-tarsal orbicularis muscle. So I'm getting a little bit of levator recession as well. And then I just close the lid crease. And so this works very, very well. These are patients that have had their weights placed. You can't see them at all. It makes a good lid crease as well. In pediatric patients, I really like platinum, and I also like them early. And again, I think it's important in these patients just also to remember that pretarsal weights do induce a little bit of astigmatism. These high weights do not induce any astigmatism, which is especially important in children. Lastly, I'd just like to talk about the lower eyelid. To me, this is really a retraction. Even though the books tell you that this is an ectropion, I really think that it's a retraction more than anything else. And so I like to recess the lower lid retractors. If you think about it, we have the orbicularis, which are the protractors. We have the lower lid retractors, which are basically working unopposed. So you need to weaken those retractors. And so the way in which I do this is that I will do a retractor recession with a spacer. That spacer can either be commercially available, or you can use fascia, or you can use sclera, or you could use even ear cartilage. I do a lateral tarsal strip with this, a medial tarsorrhaphy. They get placed on a frost suture for 1 week. Sometimes I'll do a cheek lift. But this is my go-to for these patients. So I do a lateral canthotomy, inferior cantholysis, then going to make a transconjunctival incision inferior to the inferior border of the tarsus, and I'm going to dissect between the orbicularis muscle and the orbital septum down to the inferior orbital rim. Sometimes I'll do a cheek lift with this, as in this case, and then I'm going to dissect between the conjunctiva and the lower lid retractors. I'm going to place a spacer that is an acellular dermal matrix. It's commercially available, and this gets placed between the cut end of the lower lid retractors and the inferior border of the tarsus. Again, you can use whatever spacer you want here. You could use sclera, you could use ear cartilage, you could use fascia, you could use dermis fat, but this just gets, since this is not epithelialized, I'm going to cover it with the conjunctiva. The conjunctiva is going to cover it, and then I'm going to do my typical lateral tarsal strip as we saw yesterday in the nice presentation on the lateral tarsal strip, as we've done before, and then I'm going to place a frost suture. So, before and after, I think this is, again, one of my favorite procedures to perform on these patients. So again, I love taking care of facial nerve palsy patients. I think that, there are a few tricks that I've learned over the years. And one of which with the brow is to make that medial cut back to bring up the medial brow with the weight placement. Again, I only like platinum, and I like to place it high. And then for the lower eyelid, I really like to repair the retraction, because I think that there's this component of retraction. I used to just do lateral tarsal strips to fix this, and now I found that they almost always fail with time. And so now that I recess the retractors, I think I get a much better result. Thank you very much.
Thank you so much, sir, for your wonderful mesmerizing talk. We have learned so much from you. Any question? We are actually very short of the time. We are left with only 2 presentations. I would like to invite Dr. Abdurrahman Akhtar, whose talk is about lateral tarsal strip method and benefits.
So I think we a lot of listening about lateral tarsal strip. So I also found very beneficial and a very easy method. And I think the lot of indication, the man who just invent that, he just passed away last year, Professor Ricky Anderson, and a lot of contribution he has in oculoplastic surgery, and especially maybe Dr. Richard Allen know him very well. He's also from USA, so everyone is tributing him. Even the British BOPS, they just give him the lower title. So he just invent this procedure. 1979, they just the first publication. So the main indication and benefits. In many type of surgery, you can add that lateral tarsal strip, and my goal to just we have to be in PGR level. We have to be introduced in our oculoplastic when they are coming for oculoplastic rotation. So they have to be learn this very unique and very minimal invasive procedure, and that will be fit with every other surgeries. So this is a basic thing like ectopion correction already we know very well, but something like LTS also the positively affect all 3 major components of the horizontal lid laxity and the weakening of the eyelid detectors and override by the orbicular oculi muscles. very nicely addressed by LTS. And floppy eyelid syndrome, it is always now considered. There is one paper in UK, they just found 15 patients, they just make this comparison, and they found LTS is superior from wedge section for floppy eyelid syndrome. Aesthetic point of view, it will be help for cheek mid-facial fit combined with upper lower blepharoplasties. And from like congenital point of view, there is some publication as well. They combine this procedure with uroblephron surgery, epiblephron surgery, and ophthalmic the lower lid eyelid correction, like implant is not staying in the eye, or conforma, these all stuff to just tie the lower lid. Later process have beneficial for that. Surgical approach to the orbit with this procedure, tumor resection, and periosteal flap, and even the free tarsal grafts. These all we have to be get benefit with the LTS procedure. LTS is very simple, very easy, highly beneficial surgical procedure for patient and ophthalmologist. LTS is not specified to only oculoplasty subspecialty, so other subspecialty can also get benefit from this procedure. And this procedure already we included in our postgraduate resident program in Ireland when they are coming to for rotation. So every the oculoplasty surgeon have to be like 4 or 5. They have to be complete in their that period of time when they are in oculoplastic residency program. So I expect these all things in our residency program, like in MS curriculum or FCPS curriculum. We have to be just taught our residents who are taking the degrees, and after that they go to the periphery and beneficial for the entropion or ectropion or many other things. They have to be referred these all the way back to the main cities. Just go to that surgeon and only he is doing this surgery. So if we teach them, the patient traveling time and patient is beneficial, and ophthalmologist also get benefit as well. So method is very easy. Surgical, like local anesthesia, and after that little orbic canthotomy performed with the lower cantholysis done to the exposed little lower border of the tarsal plate. Separate anterior posterior lamella. Tarsal strip incision is made along outer margin of the eyelid and involving the tarsus. After that, tarsus is when you expose, and it have to be excised according to the need, which person you have to be, like how much correction, different way of correction. So I just, the time is very short. So the first step, the second, you'll just expose the posterior tarsal conjunctival layer, sometime cauterize, sometime excise with the blade, simple blade. And after that, when exposed the later tarsal strip, after that you have to be cut according to the need of the patient. And after that, the best thing you have to be attach it with lateral orbital margin. This is the add with the blepharoplasty, upper lid blepharoplasty, and the best catch point, the golden point, where we have to be like the special you get the benefit where you have to be anchor the superior stitch anchor nearly 2 to 3 millimeter above the medial canthus. That is like one of the catch point, or we have to be say. And the second thing, make sure lateral orbital periosteum bite included during the anchoring. And simple, the LTS procedure remain an important basic technique in ophthalmic plastic surgery. Safe, fast, easy, combined with other techniques as well. And there are some elderly patients not want to travel away from the that area which I am working, like entropion correction, even the blepharoplasty effect, no need, simple correction. Sometimes we have to be combined with the here they are combined with the medial spindle, and also the 3-snip procedure. You can combine with them as well for whole lower lid. And at the end, we just want to be introduce our this famous this one of the organization we just made, and our full support with the Irish Pakistani Professional Association. The main purpose when you go online on this, anyone have to be applied. The aim is written here: finance assistance for medical students. Any students who are studying, at the moment 250 students are enrolled. We just give full support them their tuition fees from the first year until 5th year for their medical school, with the books and with the residence covers. Very easy, just go online and make that form download, and some doctor will be interview them from the UK or from Ireland, and after that, if they're selected, we are covering them for their whole medical expenses who are not affording. Thank you.
Thank you so much. Our last talk is by Dr. Zahir Shah. Is he here? Yes. His talk is about surgical management of plexiform neoform.
Today we will discuss the management of the mechanical ptosis due to plexiform neuroma. Ocular manifestation of the neurofibromatosis. You all know that you would have observed the prominent corneal nerve fibers in plexiform neuroma, which are usually seems to be translucent or transparent. Least nodules on the iris, optic nerve and brainstem glioma, glaucoma, and astrocytic hematoma, and retinal capillary hemangioma, and plexiform neuroma. These are the ocular manifestations of the neurofibromatosis. Plexiform neurofibroma, lesion affecting long nerves and nerve plexus. Epidemiology: 30% of these patients have neurofibromatosis 1. Presentation: subcutaneous lesion feel like bag of worms. Pathology: neuroma extending epineurium and surrounding tissue. Clinical: how will you assess clinically? First, observation, then palpation, and then photography, and then systemic neurological examination. You know about the neurofibromatosis because they have also systemic manifestation like capiolus, spars, and fibroma molluscum. All these you can observe these. Investigation: CT on infiltrative subcutaneous lesion, MRI T1 hypertense lesion and T2 hypertense lesion, and biopsy report. Differential diagnosis: how it includes the sarcoma, plexiform schwannoma, and lymphatic malformation, venous malformation. Medical treatment: this is a selemtinib FDA drug approved, which is used for the plexiform. It is medical treatment for the plexiform neuroma. First dose is given 20 milligrams orally in the morning and 10 milligrams in the evening for 28 days. And second dose is 10 milligrams orally for 1 month. Mechanism of action: it reduces the cellular proliferation and prevent pre-apoptic signal transduction. Pre-apoptic, it means that it prevents the signal formation for the new cells. Case history: a 15-year-old boy from Shangla presented us with a plexiform neuroma, mechanical ptosis, and ectopia of the upper lid, having vision in the right eye 6 and vision in the left eye 6. No other significant clinical findings were present. Plan of the surgery for plexiform neuroma of the upper lid: shortening of the lateral half of the upper lid, lateral canthotomy, reconstruction of the upper lid, levator muscle resection upper lid, and lateral torsography plus procedure was performed with the one-go operation surgery. So now here is the case of plexiform neuroma. You can see in the second, this is the marking of the surgical points. These are the surgical points, and this is after surgery. So previously you thought that plexiform neuroma is difficult by surgery as well as by the medical treatment, but you can have now medical treatment plus surgical treatment, and the recurrent chances are very less. Thank you very much.
Thank you so much, sir. Now I would like to request Chairperson Professor Amir Yaqub to conclude this session.
A very interesting and varied session. We had lovely presentation from all the presenters. Especially had a good session with Richard, learning about a lot of new things. And as usual, Professor Imran Akram Saaf with his innovative ideas. And I'll, in the end, I'll like to thank all the participants, the audience, as well as the presenters for their participation here. Thank you very much.
I would request the chairman kindly give me a couple of minutes because this was the last session of oculoplastic program. I must thank all the team of Ophthalmological Society of Pakistan Lahore branch who helped in preparing this program. And here is the team. Obviously, we had the support of the chairman, scientific program, and the office bearers. But most of the time it was man behind the gun, Dr. Salman. May I request Professor Richard Allen to come on the stage and give a shield to our senior professor, Professor Imran Akram Sahab. Please, Richard, can you come? And afterwards, Professor Imran would give a few gifts to Richard Allen.